Thanks very much indeed, June, for inviting me. I haven't got far to come nowadays because I do work in the hospice here, but that's the first I heard about me being a substitute for someone else, or a replacement, really. We're going to talk about opioid toxicity today, which I'm sure you've seen a lot of this. There's a handout which I'll ask June to hand round, and Susan's going to come round afterwards and collect £1 from each of you for the handout. Serious? Anyway, this is the format today of the talk. I'm going to say a little bit about the background to opioids, and then just refresh you, if you need refreshed after your lovely lunch, on the side effects of opioids, talk about toxicity, and a couple of case histories. So if you want to ask questions during this, if there's anything you're not clear about, that's fine. Otherwise, we'll take questions at the end. There are multiple numbers of opioids now that are available. When I first started in this particular specialty, morphine, diamorphine, and oxycodone suppositories were the available opioids that were used, but now there's morphine, oxycodone, hydromorphone, fentanyl, and methadone. And we have to be aware of all of these opioids in today's world, because you will come across patients on one or other of these opioids throughout your career. I think it's important to just dwell for a second on the opioids themselves, the different opioids. They're all chemicals, they're all molecules, but they're all different structures. But predominantly they stimulate the mu, kappa and delta receptors in your body. And because they're different entities, different shaped molecules, as you can see here, they have a different effect on each receptor in terms of the intensity. And the opioid effect is actually caused by the intensity of the affinity of the opioid for the receptor, and the specific fit that the opioid molecule has to the receptor. So from that fit you get the pharmacodynamic effect, which is the effect that you want from the opioid or from any drug when it locks onto a receptor. In the supraspinal analgesic effect in the brain, the mu1 receptors are the receptors that morphine locks onto. But for respiratory depression, the mu2 receptors are attached to by the morphine molecule. And you can see that sedation and spinal analgesia is mediated predominantly through the kappa receptors. We used to talk only of mu, kappa and delta receptors, but they're now known to be mu1, mu2 and mu3 type receptors. So there's not only a difference between the actual opioid molecules and the way they attach to the receptors, but there's a difference between the opioid receptors in the body. And in this group of people here today, we'll all have different ratios of mu1 to mu2 to mu3. So that immediately brings about the possibility of us all responding slightly differently to morphine if we were given morphine. And I believe that's the plan later this afternoon. So each opioid stimulates the message really from this slide is that each opioid stimulates the receptors slightly differently. And that means that opioids have the same spectrum of side effects. All the side effects are the same amongst all the opioids, but the intensity of the side effects differs between these drugs because of what I've just said. The side effects are well known to you, I'm sure, and many of these side effects are in fact transient. They last for 4 or 5 days in most cases. Constipation persists forever if you're taking opioids, and 99% of people will require to take laxatives if they're on opioids. Nausea and vomiting, drowsiness, itching. Itching's quite rare, but it does occur. In 30 odd years of working in this particular specialty, I've only seen a handful of people who've had severe itch from opioids. It'd be interesting to hear your own experiences about that. And all these other side effects that you can see listed there. Urinary retention as well is something you've got to look out for, especially in elder men who have got enlarged prostate glands. However, if we move on to what we want to talk about today, it's opioid toxicity. And I'm sure you will recognize this when you see it. Families will say the patient, the person who's the patient, has just not been themselves recently, slightly agitated. They often exhibit this sort of restlessness for a while before they develop the true full-blown toxicity. If you ask them, have they been having vivid dreams, they'll say yes. If you say, have you noticed anything different about your sleep recently, then they may say, oh yes, I've been having vivid dreams, or no. So don't ask a closed question, ask an open question on that particular subject. And don't ask them if you've been seeing things. Ask them, have you noticed anything different about your vision, your eyesight recently? And eventually they'll get to the fact that, yes, I have been seeing things not quite normal. And usually these are shadows at the periphery of their vision. You'll see them looking back and forwards. And normally these hallucinations are not real hallucinations, so they're called pseudo-hallucinations. If you're psychotic and you hallucinate, then you believe what you're seeing is real. If you're opioid toxic and you see things, you normally think that they're not real. You reassure yourself when you look and you see that the dog you think sitting there, you put your hand out to stroke it, it's not there, and it reassures you. However, people who are opioid toxic can get real hallucinations, and they can be very frightening too. And then you can get, the patient can get myoclonus, which I'm sure you've seen as well. It's a very specific type of muscle jerking, and they may say, when I'm drinking a cup of tea, my arm jerks and I spill it, or I can't take my soup anymore because my arm's jerking and I keep spilling it. It's very akin to the kind of feeling you get when you're dropping asleep at night and your leg or your arm jerks suddenly. So hypnagogic jerking, that's called, hypnagogic myoclonus. But this is opioid toxicity, myoclonic movements. This is a precursor to moving on to having a grand mal convulsion, so it's important you pay attention when you notice these things and do something about it. Late opioid toxicity is what we want to avoid. Respiratory depression, respiratory rate falling below 10 is a warning sign that this is serious. Bradycardia, very occasionally tachycardia, but usually it's a bradycardia. Hypotension, if the blood pressure is very low, then there's a serious prognosis for the patient. Coma and ultimate death if nothing's done about it. Opioid drugs are very safe to use if you follow the guidelines properly. They can be one of the safest group of drugs there is, but they're very dangerous if the guidelines aren't followed. So what are the mechanisms of opioid toxicity? Well, there's two really. There's a genetic background to the occurrence of opioid toxicity, and there's the problem with the kidneys, the renal problems. So I'll just go through our case histories, and we'll talk about the genetic and the renal side of things. The first case history will illustrate a genetic basis for opioid toxicity. We've got a 76-year-old lady who's got metastatic breast cancer. She's known to have liver metastases, and she develops right hypochondrial pain. This pain is sharp. It's there on movement and respiration. She has to stop on inspiration because the pain is so severe. It's almost like a pleuritic pain. It's a very severe intensity. It's there all the time, but its intensity does fluctuate. And it radiates to her right shoulder. So what's the cause of this pain? The cause of this pain is hepatic capsular pain, which is a very sore, painful type of pain. It could be confused with pleuritic pulmonary pain, but it's hepatic capsular pain, the fact it's radiating to the right shoulder. If you listen over the liver with the stethoscope, you can often hear a rubbing sound when people have got this kind of pain. She's taking cocodamol, the usual dose, 3,500, 2 tablets 4 times a day, which is 240 milligrams of codeine. Divide that by 10, it gives you the morphine dose, which is 24 milligrams a day. And she's put on Oromorph 5 milligrams 4 hourly for this pain. Paracetamol is added to her regime, and her pain persists, and the Oromorph is increased to 10 milligrams 4 hourly, and she may be taking this 5 or 6 times a day. The family notice a bit of agitation, but her pain settles and she's converted after titration upwards to 60 milligrams of MST 12 hourly. The pain worsens and she's taking more Oromorph. She becomes sleepy, she becomes confused, she starts to have vivid dreams, she's hallucinating, and she starts with myoclonus. What is happening? Well, she's developing opioid toxicity. What would you do? What you would do is you would check the biochemistry, you would stop the MST, you would reduce the dose of the morphine, you would convert to a normal release morphine. We'll come back to that in a minute. Why has this happened? It appears in this case, the biochemistry is normal, it appears in this case that this patient is intolerant of morphine. You've ruled out renal impairment, you don't need to switch to, you're going to switch to a different opioid because she is intolerant to morphine obviously, and our normal sequence of use of opioids in this situation would be to use morphine first. Unfortunately, she cannot tolerate this, so you're going to take oxycodone as your second line opioid. If that doesn't work, you're going to use hydromorphone as your third line. If her pain becomes stable, and obviously it's not likely to be stable at this time, you could use a fentanyl patch, another different opioid. If you're not sure of her renal status, if it's taking time to get the U's back, then you can use alfentanil, which is a different opioid obviously. It's given by continuous subcutaneous infusion. It can't be given orally, but it's safe in if the renal function has deteriorated. But we had no deterioration of renal function in this patient, so we would switch to oxycodone. Just a brief word about converting from morphine to oxycodone or any of the other drugs. You need to know the conversions, and the website at the bottom is the Palliative Care Greater Glasgow and Clyde website. It has the guidelines for opioid conversion on it, so it's worth looking at that. And you can see that if the patient's on morphine, you want to convert to oral oxycodone, you would divide by 2 to get to the correct dose of oxycodone. So if you're on 60 milligrams of MST, it would be 30 milligrams of oxycodone over 24 hours. These are estimates really, because it's difficult to be sure whether a patient who absorbs 60% of the dose of morphine that they're given will absorb 60% of the dose of oxycodone. They may absorb more of the oxycodone, they may absorb less of it. So when you do convert, there's a little bit of time that's spent titrating up and down to get the correct dose. If you're not able to obtain the biochemistry, then you could, as I've said, go on to subcutaneous alfentanil, and you would convert your oral morphine dose to your subcutaneous diamorphine and divide that by 10 to get the equivalent alfentanil dose. So this is a second case. This is a patient who has metastatic prostatic cancer. He's intellectually intact. He's complaining of low back pain. He's on MST 60 milligrams 12 hourly. He's also getting paracetamol. He's got a past history of hypertension and cardiac failure. His back pain worsens and he gets a non-steroidal added to his regime. This helps his pain, but unfortunately 3 days later he gets a bit sleepy. He becomes confused, he's hallucinating, pseudo-hallucinations, he's myoclonic, and what is going on there? Obviously, it's unlikely to be an intolerance to his morphine, as he's been quite settled on it. There's been no problem. But a new drug's been added to his regime, which is the diclofenac. One of the side effects of diclofenac is nephrotoxicity. And as you know, opioids, most of them are metabolized into substances which are water soluble and are excreted in the urine. If you damage the tubules of the urine, then these substances can't be excreted and they build up in the body and they cause opioid toxicity. So what would you do? You'd send off bloods for U's and E's. You would encourage oral fluids. You might need to give subcut fluids or intravenous fluids, depends on the setting and the severity. If the patient's at home, you might not be able to manage this at home. You might be able to manage at home. If not, he'd need to, if they require IV fluids, they'd obviously need to go into hospital. Stop the non-steroidal anti-inflammatory drug and the MST, and reduce the morphine dose by 1/3. You can continue with morphine because the problem isn't a genetic intolerance of the morphine, it's a problem of excreting your morphine from your body. If you can't get the U's and E's, then again you can consider alfentanil. Stop the morphine and consider alfentanil. You would use normal release morphine in this situation because obviously the effect of normal release wears off much quicker than MST. MST will take much longer to wear off if you give one tablet than a dose of Oromorph. Your new dose of Oromorph will be 15 milligrams every 4 hours, and that is a 1/3 reduction in the amount of morphine. You have to monitor the situation carefully. If the renal impairment doesn't improve, then you have to follow the guidelines for opioids and their use in renal impairment. That is, you can still use small doses of morphine, but they have to be given less frequently than we would normally, maybe 6 hourly, maybe 8 hourly. Or you can consider switching to alfentanil. This patient generally gradually improves over the next 36 hours. Fortunately, with non-steroidal anti-inflammatory drug effects on the kidneys, if you stop the drug and you rehydrate the patient, then their renal function generally improves over a few days. You keep monitoring this until their U's and E's are back to normal, then you can put the person back on MST. It's a good idea. In this case, the patient didn't have the optimum adjuvants in their regime, so you can add gabapentin, which will help bone pain, and you can also use the 5% lignocaine plasters, which are a useful adjunct in this particular situation, and they don't have any systemic effect if the guidelines are followed. Typical sort of U's and E's you would expect in this kind of patient who's had early tubular toxicity from the non-steroidal would be, as is shown there, the urea is 2.5 times the upper limit of normal, the creatinine's normal, the potassium is beginning to get up high, 5.5 is reaching high levels. So the creatinine being normal, the urea being high means that the patient's got dehydrated because they've been sleepy, and that just has added to the problems of the toxicity. In the first case then, we've shown that opioid toxicity has developed because of a genetic variation between, it could be the receptors. We all have different genes for our receptors. There's a predominant type within the population, but there are a small percentage of people who don't have the appropriate or have different receptors, different allotypes of receptors. Transport may be different too, because enzymes are used in transporting the drug across the mucous membranes in the or the mucosa of the gut, and sometimes these transport mechanisms work well. In other people, they don't have the correct genetic balance to transport the drugs quickly. Metabolism is another issue that again is genetic dependent. For instance, in the Caucasian population, 10% of us won't be able to metabolize codeine because we don't have the necessary enzymes to break it down into morphine to make it effective as a painkiller. In people of Japanese ethnicity, 50% of that race don't have the enzyme. So there's a genetic basis for the lack of the enzymes throughout the world's population. There's a genetic basis in some of our patients when they're not responding well to opioids and developing opioid toxicity. The net result is that glucuronides accumulate. These are the breakdown products of most of the opioids, not all of them, and they're normally excreted through the kidneys. If the kidney isn't managing to do that, then the toxicity will develop. Alfentanil is broken down chiefly in the liver, and some of it's excreted in the bile. It doesn't have toxic metabolites, so it's the drug that tends to be used in patients with renal impairment. In the second case, though, the problem was because of renal toxicity, and that was iatrogenic. It was due to the fact that the patient was given a non-steroidal anti-inflammatory drug, despite the fact they had a history of hypertension and they had a history of heart failure. If you've got both of those, then you have a higher chance of developing toxicity from non-steroidals, and the glucuronides accumulated there too. So, in conclusion, it's important to look out for any subtle changes near the beginning of the development of opioid toxicity, and also to be sure that people who are prescribing drugs, especially non-steroidals, know that there's a much higher rate of renal toxicity in those over the age of 65 who have a degree of heart failure, who've got a history of hypertension, and if they're given a non-steroidal, they've got a much higher chance of developing problems which will reflect on their ability to handle their opioid. Also, if opioids are increased too fast and the person isn't given a chance to develop tolerance to the drug, then you can get opioid toxicity also. And it is important in this situation that you act quickly, because it's usually a reversible situation, and if you leave it too long, then you can run into big trouble, and patients can actually succumb and die from this. So that's all I've got to say on this particular topic, but I'm happy to take any questions from you if you have any questions. Thanks very much. I think in the normal healthy patient, it is the transport mechanisms across the gut mucosa. Most opioids and most drugs are absorbed in the upper small bowel in the second part of the jejunum, and you have transport enzymes there that will carry the drug across. You have transport enzymes also carrying the drugs from the sinuses in the liver into the actual liver cells, where the cytochrome enzymes are present, which break the drugs down and metabolize them. So the transport there, the transport systems are both in the mucosa and in the liver. And also, of course, carrying the drug around the body is another issue. A lot of these drugs are strongly protein bound. If you have a low protein, then there's going to be more free drug available than there would be if you've got a high protein. So that can be a reflection on the illness of the patient, because obviously patients who are severely ill often have low proteins and they don't carry drugs around quite as well. I think it depends on the severity of the renal function, and the guidelines suggest that if the GFR is less than 30, then you shouldn't use morphine, oxycodone, hydromorphone. You should use alfentanil or fentanyl. And if they're less than 15, you should use alfentanil. But if they're higher, if it's higher than that, if the GFR, the glomerular filtration rate, is greater than 30, then you can use small doses of morphine, but you'd have to monitor the situation very closely. So in someone in that particular category, you'd want to use, instead of maybe 10 milligrams of morphine every 4 hours for a 50-year-old man, you would want to use maybe 2.5 milligrams of morphine every 4 hours. So you'd go much lower, and you can reduce the frequency, but you'd have to monitor it very closely. And everybody in the team looking after the patient needs to be aware of that. If it didn't get better, if the opioid toxicity didn't get better, if the opioid toxicity doesn't get better and you've stopped the drug, then if you wait a particular length of time and the drug hasn't been washed out of the body, then I don't think it's opioid toxicity. It will eventually leave the system. Dialysis is the only other way of removing the opioid if required, if you were in a desperate situation. And I suppose you need someone else in the house just to be there for the person too. That would help, wouldn't it? Because the patient might just be mildly confused and a wee bit myoclonic, but he would need someone, or she would need someone around to look after them. So it's possible to manage the mild. It's recognising that it's the important thing, I think, really, if we recognise it. Because the last thing you want to do is heavily sedate someone who's in this state. Unless they're actually in the process of dying, then that might be the best thing to do, to actually sedate them or to give them haloperidol. Haloperidol is the drug that's normally used to try and relieve or suppress some of the symptoms of opioid toxicity when you're not actually taking steps to try and remedy the opioid toxicity because the patient's in the throes of dying. I think there is to some extent. If the patient's near the end of their life and actually dying, then I think, and their pain is relatively well controlled, you might want to just continue and to use some haloperidol to try and dampen down any side effects. If they're actually distressed by the side effects, though, it probably is worth changing to a different drug, because we never know how long someone's going to live, and they sometimes live longer than we think. So you don't want them suffering, so I think you would switch to a different drug, really. People who have vivid dreams, they're not nightmares, they don't tend to frighten them, usually anyway, so they can cope with the vivid dreams. They just seem to be, the colours are brighter, everything's a bit more distinct in their dreams, and if they have hallucinations, pseudo-hallucinations, which are not frightening to them, then they might tolerate those as well. Balanced again against good pain control. Because when you do switch to a different opioid, you may lose control of the pain for a few days until you get the equivalent or slightly higher dose going into the patient. But usually you can find an alternative opioid that will suit the patient. Well, it is, yes, it is, I think. It's a very difficult ethical, moral, legal issue, actually, when someone unfortunately gets very toxic on a drug for any reason. They may have taken the wrong dose or whatever it is, but they're in a palliative care category with very advanced disease. Do you send them into hospital for sort of stomach washout, for an naloxone infusion, or not? These are issues which are very difficult, and I think you have to take each case individually and discuss it. And I think the main thing is always to try and act with the patient's best interests at heart. Sometimes the patient might be unconscious, and then it's the relatives you've got to liaise with, and they may be wanting the patient hospitalised, or they may be wanting to keep the person at home. But if there is a chance of actually reversing the toxicity, the seriousness of the situation with naloxone, and you don't take that, you've got to have a good reason for that. And it's important that people in that situation, health professionals in that situation, don't take that decision on their own, that they consult with others and get their view, and hopefully you get a consensus view on what's the right thing to do, and then go ahead with that. But you've got to be able to justify that on all sorts of different levels, ethically, morally, legally. But when someone is mildly opioid toxic, verging on a wee bit of respiratory depression, what we normally do is we monitor them closely. We monitor their saturations, oxygen saturations, their respiratory rate, and we try not to give any naloxone. Because has anybody seen a patient who's had too much morphine or any opioid given naloxone? A few of you are nodding. It's usually a terrifying experience for the patient, and their pain can get incredibly much worse for a short length of time when the naloxone replaces all the morphine or opioids that are on the new receptors. It knocks them off, and of course the pain just goes shooting up. And then if there's still morphine in the body and you haven't given enough naloxone, the morphine will get back onto the receptors and the pain will settle down. But the patient gets a tremendous burst of excitation with diarrhea and colic and sweating, salivation, and general distress. I saw a patient once who was lying in bed, and someone gave him some naloxone. He'd been in bed for about 10 days, hardly moving. As soon as he got his naloxone, he jumped out of the bed and smashed himself through a window. He didn't fall right through it, but he crashed into it and broke the window. So they just don't know what they're doing. So it is you've got to think seriously about whether or not to give naloxone. But it's there, that's the thing, it's there for someone who's inadvertently maybe taken it and needs to be resuscitated. Of course, if they've taken MST, if they're on MST, they will need an infusion of naloxone, not just a one-off injection. Absolutely, yes. That we're here as a resource for you if you ever want to phone us up and speak to us. And it might just be just a chat, because obviously we may not be involved with the patient at all. It might be a patient unbeknown to us, but at least you can have a chat with us, and we could mull the matter over, and then obviously you'd have to get back to the GP and speak to them about it. But you can certainly use us as a sounding board or for discussion, for information at any time.